Good morning, everybody. If you're just joining us, this is the Walker webinar on return to use policies, which we'll talk a lot more about what that is if you're new to the topic, but we're really glad to have you here. So thanks for joining. We are really pleased to have a couple guests here with us who I'll introduce in a minute, but if you're new to our webinar series, we are the Washington Alliance for Quality Recovery Residences, and we really have two primary arms. One is this, what we're doing today is our professional development technical assistance arm, in which we work with operators, providers of recovery housing in Washington State. Alongside, we have just numerous folks who we call stakeholders who are just really behind what we're doing in recovery housing, and so have an interest. I like to say have skin in the game, but have a real interest in what we're about. And so, if you are an operator of recovery residence and/or a stakeholder, you are more than welcome to be here, and hopefully that covers just about everybody. But the other piece of what we do is accreditation. We're not going to talk much about our accreditation process today, but just so you know that as an organization, we have a primary goal of really increasing the number and the quality of recovery homes in Washington State. And so to that end, we have an accreditation process that is, we feel, very user-friendly and very much aimed at just helping operators be the very best they can be. And so if you want to know more about that, please reach out to us, and we're glad to talk to you about that. So this webinar is part of a series, and you can find out more about our other offerings and what's coming up for the rest of this year. And you can see recordings of our past webinars. We try to find topics that are really interesting, that are kind of the center of conversations around the state. And so we'll continue to do that throughout the year. So we're planned out now through June. We're working on the second half of the year calendar. And so just keep go to walker.org, WAQRR.org, and click on the events button, and you'll see our events calendar, and you'll get a sense of what's coming up. So we've got some really exciting programs coming up. I will save a little announcement about that to the end of our session here today. But we've got one webinar coming up that if you sign up for it, you're entered to win a $250 gift card, which we'll tell you more about, but just wanted to whet your appetite for that. And but without further ado, I want to be sure to give our presenters time this morning to talk about this really important topic, and that is return to use policies. We are really pleased to have with us today Erin Helms and Danielle Gray from Ohio. They both work in an organization called Ohio Recovery Housing, which is basically the counterpart of Walker out in Ohio. And so for them, this is afternoon already, so they've already probably had lunch, and we're looking forward to that. So you can tell us what that's like. But let me tell you a bit about them. Danielle is the executive director of Ohio Recovery Housing, so she spends her day doing a lot of certification and professional development work, a lot of technical assistance, and so is known really across the country as somebody who just does really good work in that capacity. And a lot of us go to Danielle with questions about how they do things in Ohio. They've been at it a while, and they really have figured some things out that the rest of us are learning from. So really glad to have you here, Danielle. And then Erin Helms. Erin is an operator herself, and by operator I mean of recovery housing, and she in some capacity or other is connected to 6 recovery residences through a couple different business models. If you want to know more about that, you can talk to her. But Erin is also serves as the treasurer of Ohio Recovery Housing, so she's involved on their board. She also sits on the board of the National Alliance for Recovery Residences, and so has been connected there in a number of capacities, but one of them is really advocacy work. So she and Danielle are very involved at the national level on advocacy for recovery housing. And so as an operator, she has really unique insight into what that's about. She also is very involved in the peer movement and really believes in what that's like. So, in the benefits of that. So I'm going to stop talking here and turn it over. I think Erin is going to do the lion's share of the presenting today. So Erin, take it away. One thing I'll just say about logistics is that we're going to give you opportunities throughout the presentation to ask questions. but we'll ask that you kind of hold on to those unless there's something really pressing. Justin Cram, who's also here with us today, is our coordinator for professional development, and Justin will be monitoring the chat box. So Justin will kind of be hanging on to those questions until those question breaks. And so if you have something, put it in the chat, or during that question time, if you want to raise your hand, we can unmute you and have you actually ask the question live. So Justin will be our kind of behind the curtain wizard on all of that stuff, on all the communication pieces. But without further ado, I'll turn it over to Erin. Thank you so much for being here and being with us, you two.
Well, thank you so much, and thank you for that great introduction. Good morning, everybody. And Alan and Justin, thank you for asking us to present and talk a little bit about relapse and really what to do to prevent a relapse, and then in the event of a relapse. We very much appreciate being able to share our experience and what we've seen that has worked, and just to hopefully give you some different things to think about as your organization is working through things. I mean, as we know, COVID has really changed the world that we operate in, but being able to stick to the fundamentals of recovery housing and being able to support people with SUD, it's as deadly as a disease, and sometimes more so for some of us than even what COVID is. So it's important to continue to focus on providing good quality recovery housing in this day, especially with all of the stay-at-home orders. So our residents were asked to stay in their house, and that's where you come in to being able to really provide that support. So these are the objectives for the day. So as I said, really focusing on the prevention of relapse. There's a lot of things that as providers that we can do to really help somebody not relapse, catch it before it happens. And it really starts for us, before move-in, even at that time of application and interview, moving through while a resident is living at the recovery house. Obviously, what happens in the event of return to use or recurrence of symptoms, and then how to deal with that resident as well as the other residents living in the house. And then also being able to look at addressing mental health concerns. As we were at the before the PowerPoint started, the presentation started, we were talking about the increase that lots of people outside of even the SUD world have been struggling with, anxiety, depression, and our folks aren't immune to that as well. So it kind of feels natural to have it all fall under the same umbrella. And at least addressing some of those points for you to think about for yourself and your staff of, sharpening some of those skills. So as we go through and look here, the amount of relapse that has increased over the past year. I know a lot of us have heard anecdotally how there have been relapses, but this was a graph that I was able to find that really just shows, non-prescribed fentanyl on the increase, methamphetamine, cocaine, and overall drug cases. And this was done from 500,000 urine drug screens by Millennium Health. So we can see that, lots of people have returned to use, unfortunately. What we noticed in a lot of our recovery houses in the state of Ohio, especially the first couple of months, that we did not see an increase in relapses. So yes, there still are some people that unfortunately do relapse, but for those people living in recovery housing, we have not seen a significant increase in people being in that return to use. So just this, I felt this was kind of a good infographic to just kind of take a look at the larger population. So prior to a relapse, as I said, a lot of this is being able to set those expectations. So as an organization, we really have developed a reputation that when you move into one of our recovery houses, that you're going to stay sober, that you're going to make changes and find a new way of living. And I think that's really important to have that as part of an organization, and the way that you are, showing your face to the world, that when people come and live in your recovery house, your recovery residence, that they're going to be able to make changes. We don't guarantee anything 100%, but that, there's a good chance that if you do what you're supposed to do and you really accept the help that's being offered and you really work on making an effort to do things differently, that you've got a good chance of finding a different way to live life. So prior to move-in, part of the application process that we have is really trying to understand where the person's coming from, what their life is all about. And because most times, especially now with COVID, we're doing things over the phone. So having a good process in place that you're getting as much information to be able to make a really good decision. Are you the right place for somebody to live? I know sometimes, if you operate a level 2 recovery house, but somebody's really in need and they can't find a spot, sometimes you end up taking a chance on somebody that maybe isn't quite a good fit. But it's important for the fidelity of the organization to make sure that you're serving the right group of people. Being able to know what you provide, what you offer, and being able to make sure that the residents know what their expectations are prior to move in. So some of the things that we really look at prior to somebody moving in as part of the application and interview process is, where's the applicant currently living? Where are they coming from? What accommodations may be needed for that person? So, talk about residents who they may have been couch surfing. So what has their experience been? Have they been one of those person who puts together a couple of weeks and then relapses, or a couple of days and then relapses? Or is this person, somebody that has had a long history of use, but they've gone to treatment and it's just one time? And being able to have that information is important as you're continuing to work with them on their recovery plan. So also family of origin can really be some helpful information. If everybody in their life has been in active use and it still is in active use, then knowing that you're going to really have to work with that person of providing a huge amount of support and helping them develop a new support system. On the other hand, if you have a resident who they have a really loving family, nobody in their house has ever been an alcoholic or an addict, that families may really not have a very good understanding of what's going on with this person. So information is key here. On the flip side, some residents that we have come in, they've had some family members who have had alcoholism or drug addiction issues, and they're in recovery actually. So that can oftentimes be a really solid support person for your residents. So just being able to get that understanding of who you are dealing with, because we very much believe that there are expectations that everybody is held to, but being able to individualize what the needs are for your specific residents makes all the difference. So when we start as part of the phone interview, we set what our expectations are. So, we expect you we support multiple pathways to recovery. So that means we support, MAT, Celebrate Recovery, 12-step. The birthplace of Alcoholics Anonymous was just about 30 miles south of Cleveland. So there's a pretty strong AA hold, but that doesn't work for everybody. Refuge recovery has started to really pop up in this area a bit more, which has more Buddhist followings, and sometimes that can be helpful for some of our residents. Whichever the person's pathway to recovery is, we expect that you start working with somebody in that chosen pathway. So whether it's a sponsor, mentor, or pastor, that you find somebody within the first week that you're going to start working with. Oftentimes we talk to them about, not getting married, but that this is a person that you're picking, and you can always change. Like, that's the one part to make clear if it's not working for one reason or another. Secondly, we say that, we expect you to go to 6 meetings per week when you first start. If you're just in IOP, you have plenty of times to go to meetings. So that's our expectation. Now, they can, because of COVID, can be done virtually or in person. It's up to that person's choice, but that's not changing just because of COVID. We also expect that residents follow treatment recommendations. So if somebody's gone to residential treatment and they come to the house and they say, oh no, my treatment provider said, I could just go to meetings. That's very unlikely. So prior to somebody moving into the house, we're talking to either a counselor, a case manager, somebody from the treatment organization. If a person has not come, because we will take people who are referred from the community or referred from detox, we ask to speak to either we ask them for 2 references. It can be any 2 people, but we do ask them for 2 references to be able to get some sense of who that person really is. Also, we ask people that they get an assessment if they're coming from the community. We don't care where you go to get the assessment. We very much believe in freedom of choice for your treatment options. But once you get that assessment, following those treatment recommendations, then we discuss with them specifically in COVID of outside appointments. How are we going to help you get there? You know, buses can be sometimes dangerous because of COVID. So, and right now in Ohio, we have about 12 inches of snow on the ground. So, or at least in Northern Ohio. So being able to let them know that we'll make sure that you get to those appointments, whether it's a peer supporter, house manager, another resident, we'll help you get there. But that's one of the expectations that you're going to follow through with things like dentist appointments, psychiatry, individual therapy, and as many any things that can be done through virtual, we will support. But if not, being able to get you there in person. We also have an expectation of fellowship requirement. So we see sometimes that residents really struggle with learning how to have fun. They don't know they don't know what they like to do. They don't know what hobbies they enjoy. So that's the other part, that we require at least 1 fellowship activity per week, and that's been helpful to really support our residents in looking outside of, you know, just the nuts and bolts of things, as far as just feeling like everything's work. That you've got to learn to enjoy yourself, because quite frankly, if you don't enjoy yourself in recovery, you're not going to last very long. We also address family visits. So currently now with COVID, we are allowing family visits, but they have been reduced. And right now we only allow 3 overnights per month, and it has to be at the same place for that entire month. So if you're picking to go to your mom's house, that's absolutely fine, but your 3 overnights are all going to be at your mom's house. Additionally, we do review things specific to COVID-19. So what we do as part of to comply with what the governor has suggested. So, you know, we take your temperature upon arrival. We talk to people about their symptoms prior to getting there. And we're not saying no if somebody has COVID. We're just saying, okay, you need to be able to quarantine before you move into the house. Obviously, the whole, all the specifics with COVID is a whole nother topic, but I think it's important to set the expectations prior to somebody moving in, to let them know really what your recovery house is going to provide and what's going to be expected of them. Here's just a couple more. You know, we believe that service work is really important to helping a person find their way in long-term recovery. We've seen service work opportunities really be, it's been challenging to find how our residents can do service work, because so many meetings, in-person meetings, have closed down. So we've taken the wiping the surfaces, the hard surfaces, down 3 times a day as a service work opportunity in the recovery house. So I would challenge you to think about the expectations of your recovery house. How can you have your residents really take ownership of that safety portion of COVID, and making sure that they are doing what they need to do? One, it helps keep that house safe, but secondly, you're teaching them life skills for when they move out into their own either apartment or house, or move back in with their family, that they have some good skills that they're taking with them. Obviously, a pandemic has not happened for 100 years, so hopefully we're not going to have another pandemic in 5 or 6 years from now, but we still have quite a ways before we're going to be able to get through this current pandemic. And having those structures in place is important, but also being able to share with them why those supports or those structures are in place, because that helps residents really change that frame of thinking of I have to do it to I want to do it because it's the right thing to do. And we know, as people, for those of us who are on long-term recovery, know that, you know, a lot of what recovery is about doing the next right thing. So we look for every opportunity to have our residents see how can they do the next right thing. So I'll pause here for a moment to see if anybody has any questions about, you know, prior to move in, the application process, phone interview, anything Any questions that anybody has? Anything in the chat? Okay, and there will be plenty of more times for questions as we go along. So keep moving through because we got a lot of good information. So thinking about, you've accepted the resident, how can we go through and support this person from the very beginning of day one as part of their move-in process? So when we talk about the as part of the move-in, we talk to them about COVID right from the beginning. And part of this is important that they know what they're, as I said, what they're getting. So this is just an example that I wanted to share as part of our plan, that we have every person in our recovery house read this short story about Bob, who went to a dinner, a funeral, and a birthday party, and how he spread the COVID-19 to 16 other people, and 3 of those people actually ended up dying. So it starts for us being able to help the residents understand that your actions have consequences, and what you do can impact other people, and what those impacts, how you impact other people, really, how is that going to make you feel? So we then follow this up by talking about personal responsibility. How can you be selfless? How can we support one another? And the main reason that I share this from the beginning is that a lot of preventing a relapse is having that open communication, creating a space that people feel comfortable with being honest. They're able to talk about what's really going on with them. Now, I am not suggesting that a house manager or a peer support replace a sponsor, but what we've noticed is that our house manager and peer supporter, because they're around so much when the person's first moving in, and really throughout their stay, are oftentimes know them better than their sponsor does for some time, until that person really gets into working the steps, whether it's a sponsor, mentor, or pastor. We're going to know them better from the beginning. So having those open dialogue conversations has really shown to be really beneficial to our residents, because they know that they have at least one person in their life that genuinely cares about them, and that they can go and talk to when they're having a struggle. So we also then followed up about, what really is personal responsibility, and being able to take personal responsibility for our actions is something that most people in early stages of recovery are, quite frankly, just terrible at. In active addiction, so much of it is living in the shadows, being able to see how can we not have people ask us questions? How can we just get by to be able to get that next drink or that next fix? And it's really, it's not transparent whatsoever. And we honestly don't really like to be accountable to anybody. So, and I say we, because as I said, I'm a person in long-term recovery. So knowing how people in early recovery act is vital. But being able to start these conversations and talking to our residents, your life is full of choices, and what you do with them governs your entire reality. Being able to see that your decisions have a direct impact on the lives of others as well as your own is really what personal responsibility is all about. It doesn't matter where you fall on the spectrum of the simplicity of your life, whether whether you're a PhD student or whether you've just gotten your GED. That, intelligence doesn't really play a part of taking personal responsibility. You can go through and you can make changes, very simple changes from day one, and being able to own up to what your life is today and what you're doing today is building a foundation for long-term recovery. And that's really what we're looking for, is how we can build that solid foundation for each and every one of our residents. So we talk a little bit about, these are our specific protocols. So when we talk about, this is in general, is this something that's essential? Is this a need or a want? That question, I have to say, is one of the most fundamental parts of being able to work with residents when they're trying to make decisions. Because we're not somebody's sponsor. We're not their, we're not their pastor. We are there to be able to really help them learn how to make new decisions. But really, we're not going to make the decision for them. Now, there's certain circumstances that, yes, we are going to make the decision, but we've found that it's much more important if you can ask the person the question and they can come to the idea of what's a better choice versus us just telling them no. So then obviously we talk about wearing masks whenever they leave the house. That's specific to COVID. But across the board, we are always talking about what's the next right thing. How can you really get your brain into a new training of what is the next right thing? And then is your next right thing continuing to stay home when you can? That's obviously, that one's also specific to COVID, because let's face it, I mean, you can't really turn on the TV without something being talking about COVID, have a conversation with a family member or a group without talking about COVID. So we recognize that that's intertwined into everything that we're doing right now. Hopefully soon down the line, once more vaccines are getting out there and more people are getting vaccinated, or we're reaching herd immunity, whatever your preference is, that people are able to, we're able to return to some sense of normal. But as I said, I mean, I've heard anywhere from 18 months to 2 years before that's going to happen. So we've got, quite a bit more time of working this way in the world. And it's important for us to be able to help our residents find a new way to work. So I'm going to pause briefly for questions. Does anybody have anything with regards to prior to move in, or, when that person first moves in?
Just really quickly, I see that right as we were finishing up the last question section, Sarah Barrett had said, have you had any issues with COVID cases in the house?
Yes, we have. We have had, actually at this point, so we have a total of 6 recovery houses. As Alan said earlier, we've had 10 residents and 2 staff people who have had COVID. At the very beginning, within the first 2 weeks of kind of everything, the end of March, one of our residents had traveled out of state and came back and was positive for COVID. So we worked with the Ohio Department of Health and Ohio Recovery Housing to go through and set protocols, because a lot of the protocols that were out there were really just about keeping somebody safe, which is important, but we needed to look at it from a recovery perspective. So both on the NAR website and Ohio Recovery Housing website, we have a list of our protocols for specific to level 2 houses. So we operate mainly level 2 houses. We have one level 1 house, but and it pretty much operates the same of how to really support that person. So we don't want to just put a person in a room and say, we'll see you in 10 or 14 days. We have to keep them engaged with their recovery supports, engaged in the recovery house, being able to check on them, making sure that they're getting food, and how do you, if you have, how does somebody be able to use a common shared bathroom? So those things are listed on there, and I'm more than happy to send those over after the presentation of what the protocols are that we have seen that has worked. So yes, we've had real life experience, and for the beginning part, it was only residents that had been positive for COVID, and we were able to, that was much easier to manage. I have to say, definitely was a little bit more challenging with having staff. Our staff are paid staff. They do, however, in all of our recovery houses, we have a third floor apartment that we have a house manager that lives there, that she works part of the time, but then also lives on site just for emergencies overnight. And I have to say, it was kind of challenging having that person. So we had to put extra support in place, and it was a challenging 3-week period of time, because just the overlapping, and by the time it kind of worked through, it was challenging, but we did make it through, and fortunately everybody's doing well now. So, and like I said, I can share those protocols afterwards, and you can send those out to everybody. And then I'm always more than happy to have a follow-up conversation specific to COVID questions as well. So next is being able to really look at the stages of relapse, that somebody doesn't just pick up one day and relapse. So there's typically a lead up to that. So first you have the emotional phase, that during this phase, they're not thinking about, they're not necessarily even thinking about using, but some of the thoughts and behaviors are setting you up for a relapse. The resident is often sometimes isolating, a lot of times keeping their emotions bottled up, sometimes feelings of anxiety or anxious, sometimes anger, sometimes not sleeping or eating well. But there's those signs that you can see somebody's not right. They're not acting in a healthy manner. Then we get to the next stage of the mental relapse. In this phase, a lot of times the person's at war with themselves. Part of them wants to use, part of them doesn't. Part of them knows that recovery is a much better way of life, but sometimes that euphoric recall starts to kick in. Sometimes, the things that people, places, and things start to come in, and you start thinking only about the good times, and stop thinking about, some of the consequences, or rationalizing it wasn't that bad. And then that's really where that bargaining can come in with, that, and planning to use. And that towards the end of that mental phase, that's a really dangerous place to be. And not always, but can sometimes lead to an actual physical relapse or return to use. And this is when that person takes that first drink or first pill, and or first fix of what their choice is. And that's the part that obviously causes the more significant trouble for a resident. But how do we go through, and how do we, one, prevent that, and two, what can we do if that person does reach that stage of return to use? So partly being able to recognize and help your residents recognize what are their triggers. And this is something that oftentimes is discussed in clinical settings, and that's where a lot of it belongs. But clinical settings only happen, when somebody's in IOP for 9 to 12 hours a week, and then aftercare, 2 to 3 hours a week. And then, let's face it, in this country, people are only in treatment for, 6 weeks to 4 months. And then they're living their life, and hopefully they've learned some good skills and whatnot. But helping residents really understand what their triggers are. We also operate a workforce development program, and one of the things that they were doing was cooking. And the scale that we had purchased was the exact same scale that one of our residents had used for their drug use. And it was really a trigger. And we had to talk to the person, talk them about what they were feeling, how that, what could they do differently? How can we support them? Have they talked to this woman works a 12-step program. So has she talked to her sponsor? So some of it is identifying what the triggers are. And sometimes it's important to have these discussions, because sometimes people don't even realize what some of their triggers are. I've had residents that have said that the smell of vinegar or ketchup can be triggering to them. So the main thing that we want to get across to them is, we can't necessarily remove all triggers from your life. If this street that you happen to drive down is a trigger for you, well, don't drive down that street. But if it's the only way to get to the place you need to go, we got to figure out how to work through what those triggers are. So for us, when we think about this, again, we're not taking it from a clinical approach. We're taking it much more from a what can we do to support you approach. And the main thing that we can do is have conversations. Being able to hear somebody and really be able to listen to what they have to say is a huge part of us being able to provide that quality support living in a recovery house. Some of the things that we have recognized especially with some of our residents who have been around for a bit longer, they really had some significant anxiety and struggles with isolations. I mean, in Ohio, all outside meetings shut down for the first 5 months. Now we do have some meetings that have returned to in-person use, or in-person status, but there's still a lot of our residents that are going to Zoom meetings, and we want them going to Zoom meetings as well. But it's isolating, and not being able to actually see people in person, or having limited time with family members, having limited time with your sober support group. Those things can really be a struggle. So and again, I'm not trying to be a broken record, but a lot of it is just talking and having those open conversations that, one, they're not alone, that there's not something wrong with them, that they are, this is very normal, and this is very much something that we can work through as long as the person's willing to be open and honest and talk about it. There's not a single problem that we can't work through. So as you're going through and, identified some triggers, also being able to work through, a plan for distractions with cravings. So, and I recognize that cravings and triggers are two different things, but being able to help that resident. So hopefully when they've been in treatment, they're understanding what their cravings are, or what a craving is, what their triggers are, but learning how to be able to work through those and putting those into practice really is our responsibility, because when they're living at the house, that's what we're responsible for helping them work through. So some things may work for some residents and others may work for other residents. So listening to music may work for somebody, and for that other person, that's really not going to be helpful. We've had some residents that being able to, we have a rocking chair at all of our recovery houses, because sometimes that motion of being able to sit in a rocking chair can be very soothing for a resident. And most times you can pick up a rocking chair for relatively inexpensive, and it can be really beneficial to some of your residents. So being able to, again, this just goes to finding out what is individual to that person and being able to help them have a plan with how they're going to deal with it. One of the top things that we ask all of our residents to is talk about it. Let somebody else know what's going on in your head. And that's that slogan of a problem shared is a problem cut in half. That's something that, not only is it a slogan, but it's actually true and it actually helps. So next we look at how to build support. And this is, a picture of people together, but not really all that close together. That, we got to do things a little bit differently to build support now. So how do we help our residents build the support that they actually need for their substance use disorder, but also keep them safe? So as I said, substance use disorder for some of our residents is as deadly, if not deadlier, than COVID is. So making sure that our residents have the support that they need. So being able to teach residents how to use Zoom, how to set up a Zoom meeting, being able to be in person, but outside where there's fresh air. How to connect with a sponsor. When we've had new residents move in, a sponsor or a mentor, typically it would be at a meeting, either before or after the meeting. And sometimes with Zoom meetings, there's not that before or after the meeting. So working within the recovery community and our smaller recovery housing community of, this is a new person. She's 50-year-old woman that has 2 kids. Does anybody know of somebody that's available to sponsor that maybe she could, we could give her her number to, so she can make that call. So it's really been a little bit more work for us to be able to help connect people. But once those connections are made, it pays off tenfold. Also being able to support residents getting to either religious services, whichever that may be. That, I had a couple of residents that have gone to drive-in services because that's where there was a church that was holding religious services. And we don't require that people go to any type of religious service, but if that's something that's part of their support network and important to them, we're going to make sure that we figure out a way to make that happen. And then the fellowship part, that can be difficult because we keep telling people to stay at home and to not mingle with people as much as possible outside of their family unit. Also, at the same time, we've got to help our residents learn how to have fun again. So we took the approach this past year that we've created an activity every week or every other week, depending on the activity, for our residents to do. We've done everything from tie-dyeing to making palette signs. We did a whole letter writing campaign to our representatives. We've bought a basketball hoop at one of the houses. So it's really a variety of activities. And so initially we as staff came up with some of these activities, and quite frankly, we're kind of running out of activities. And one day I was just like, well, we need to get more input from the residents. And it was amazing to see what some of our residents came up with. We've had these beautiful art pieces created. We've had people make jewelry. It's really been quite special. So, lean on your residents. They know sometimes what they like to do, or at least sometimes they know things they'd like to try. And being able to support them has really been helpful. The other part then are those professional services, making sure that sometimes our residents come in, their teeth are just, they haven't been to a dentist in years. So helping them solve, making the appointment, getting to the appointment, that's something that we can do, because, pain is a huge, huge problem for our folks. So how do we start addressing some of those issues? And I've had more times than I care to imagine, people that are outside of the recovery house that I just know in the greater recovery community that have relapsed after some type of physical pain issue. So knowing that we have to be able to do better to be able to support our residents in working through that. As we all know, tooth pain can be really problematic. So how do we work through that, and how do we make sure that we're keeping that person safe? Also being able to make sure that they make their individual therapy appointments, psych appointments, being able to have their psych meds is important. That's part of that whole wellness approach, that person is being able to get what they need. Here's just, as I said, we did a whole variety of different things throughout COVID. And I do have to say, some of this has increased because of COVID. We had an emphasis on fellowship, but we expected the resident to really find where they enjoyed themselves and things that they did. As an organization, once a quarter, we would have some type of an event. I mean, we do pumpkin carving every year. We do cookie decorating every year. We do sled riding every year. And then we also do a barbecue every summer. So we have different ways that we get together with our residents. But in COVID, we had to assist with some of that. We had one house that they started a whole yoga program, and they do Zoom yoga a couple times a week. And now our other recovery houses actually Zoom into those meetings. Some of our residents who've moved out still continue to Zoom into those meetings. So there is that sense of connectedness that we've been able to create and continue over the course of this past year. I think it's important, really, technology wasn't something that we really focused on much prior to COVID. Every house always had a computer and a printer. So, and it was mainly more for our house manager to be able to use. And fortunately, we were able to write some different grants and do some fundraising to be able to make sure that every single house has at least 2 computers and at least 2 tablets. So on any given day, anybody who needs to be able to connect to technology is able to do so. Our recovery houses are anywhere from 5 to our maximum house has 9 residents. So we wanted to make sure that they're covered and they're being able to connect to the outside world. So I'll just pause a second for questions to see where we are with things. If anybody has any questions about that, the past section.
We did have a really quick clarifying question from Julia Reardon. She said, you said level 1 and 2 houses. What does that look like? If you want to just give a really quick.
Sure. So we have 5 level 2 houses that has a house manager. So level 2 are monitored. They're not staffed 24/7. Level 3 houses are staffed 24/7. They have a staff that's awake and there at night that are it's much more of life skills intensive, much more support and structure offered at a level 3 house. Level 2 that we offer is they're monitored. We have staff that's available a lot. We have a lot of support, but it's not the 24/7 staffing. We do individual life skills, but they're not like life skills curriculum or, our residents go out for treatment during the day. And then as they've lived with us for longer, they're getting jobs, they're working part-time, they're really rebuilding those relationships with their family. And then the level 1 is strictly peer support. So there's no staff on site. We do have a peer supporter that works with them on a monthly basis, but by the time somebody gets to a level 1 house, they're very much, they've built up quite a bit of recovery capital, and it's just really peer support, almost like an Oxford type house that people living together who are in recovery for a level 1. Okay, so hearing no other questions, we'll move on to, this is for me really some of the nuts and bolts of recovery are the recovery planning. How do we go through and are really focusing on the logistics of helping residents recognize how to make changes in their life. So first, recovery plans are resident focused. What the recovery plans differ from treatment plans in the sense that recovery plans, the resident decides what they want to work on. They're not being told you need to address, grief. If a resident's not ready to address grief at that point in time, that's not part of their goals. So how can we go through and help that resident figure out what their goals are? And when somebody first moves into the house, a lot of times it's very challenging for them to identify goals. They can oftentimes be overwhelming. Their entire life is on fire. So how do we help them start piece by piece? So when somebody first comes in, it's first about starting to build that support system. And then what are the necessary things? So do you have a food assistance card? Do you have your state ID? Do you have a checking account? Then we're building up to, as somebody's working through intensive outpatient, getting into aftercare, looking for a job. Do you have a resume? Do you have clothes to wear to a resume or to a job interview? What about viewing questions? So how do we help that person develop? Then as somebody, they get their first part-time job, or sometimes our residents come in and they already have a job. So how do you work between going to work, going to intensive outpatient, and getting to meetings? So it's really dependent upon where that person is at and how to be able to really help them meet their needs. The one thing that I will say that's most important is don't be afraid to ask the difficult questions. So if something doesn't make sense or it's not adding up, or you're seeing that somebody's really struggling in this one particular area, ask the question. Being able to discuss financial concerns, that is one that is such a struggle for so many people. And for whatever reason, a lot of times people are afraid to say, I see that, every Wednesday you're completely broke, and you don't get paid till Friday. How can we go through and set a budget? Or, you've talked about the bill collectors calling your phone 10 times a day. How can we go through and create a plan of what you're going to say to them, that they'll stop calling if you start talking to them, or, be nice to the tax department when they're calling. It's really just about having those questions. But the fundamental part of recovery planning is being able to find out what their goals are and how do we help them achieve those goals. What action steps do they need to take? So we have found that there's, we had to create some new ways for people to meet goals. So a lot of times people want to get into shape, and going to the gym. I mean, gyms have been shut down and open back up in Ohio off and on for the past 10 months. So how can we help them to be able to, go for hikes outside, be able to do yoga inside, being able to, we've gotten some weights at some of the recovery houses and some yoga mats. So we just got to know what that person wants to do and to be able to help them meet their goals. Also, some of this was, as I said, for some of our residents who had been around for some, 6-8 months, getting back to those basics. So getting back into some really good routines, really solid, shoring up your recovery. And not by any means that 6 or 8 months is a long time of being in recovery, but those are our more senior residents. So helping them find their way back to the basics. Also talking about, social connectedness. A lot of our world, got turned upside down. And we weren't able to go out and see people at meetings and be able to hang out, a half hour before the meeting or go to the clubhouse. So how do we help them connect, and how can we support people safely being able to see each other in public? Those are all parts of recovery planning to address. We also looked at, returning to work, or I'm sorry, what opportunities exist. The residents some of our residents didn't have any money for some time and then would get these huge checks from unemployment or stimulant checks. You know, $1,200 or $600 may not be a ton of money to some of us on the call, but that's, you know, that can be really changing for a resident. So getting caught back up on child support payments, or possibly paying off a student loan, or being able to save up and buy a used car. Those things are sometimes, you know, foreign to some of our residents. So how can we help them find their way to that? Even if the question is difficult, ask it, because a lot of times if we're not asking those questions, our residents make bad choices. I'm not saying that they sometimes don't make bad choices, even if we do ask the question, but it significantly decreases the amount of at least they're thinking about the choice that they've made prior to making it. The one thing that I think really important to address as part of our recovery planning was some of our residents returning to work. So we created this sheet of things to think about when you're returning to work, and we would talk through that with each of our residents, because at least for us, some of the anxiety and whatnot was really you know, detrimental to some of our residents. Also, some of them struggled with some pretty significant depression because of either not being able to work, or some of our residents that they're working actually increased. They worked at nursing facilities or in the hospitals, and they were really, you know, stretched pretty thin. So it's the main part is as part of your recovery planning, you can really help the people, the residents, learn how to set a goal, be able to have action steps, and it may just be, you know, something as simple as how to deal with work on a daily basis, and what can that resident do. You know, maybe there's a quick meditation that they can listen to on their 15-minute break. Or being able to help residents, you know, simple things like, you know, when you're washing your hands, saying the Serenity Prayer if you're on a 12-step path, or if you're in Celebrate Recovery, is there a prayer that you can say that helps calm you down? So again, it's about being individualized and helping your residents find what works for them. Part of this that is just across the board with all of our recovery planning to preventing relapses is really learning new self-care routines, being able to help our residents finding better sleep schedules. I mean, in active addiction, a lot of times people would sleep for long hours, or, you know, 2 or 3 hours a night, but being able to really find, you know, that sleeping and eating well, finding ways to relax, can really lead to better mental health overall. And people who are in better stages of mental health are significantly less likely to relapse. So a lot of this is just preventative. This is a sign that we have up at all of our recovery houses, that it's just a good daily reminder of continuing to do these things and being able to help our residents find what works for them. But these kind of daily reminders can be really helpful. So we look at this. So this is our actual recovery plan. It's very simple, very basic. We have what the goal is, what are the action steps, how will these be achieved, are there any barriers, and then the outcome or progress. It's if any of you have ever seen a treatment plan, there's goals and steps, and I mean it's none of our residents are creating their own treatment plans, but they should be empowered to create their own recovery plan. Our house managers initially start out with writing the goals down, and then as somebody's been there for some time, then it transfers over to still meeting with our house managers and still doing the recovery planning, but our residents are doing their own writing of that. And it's just that empowering part that they're continuing to take more ownership of their recovery. And we really base everything off the 8 dimensions of wellness. So here's just kind of that pretty picture that really explains what the 8 dimensions of wellness are. But we have each resident go through on a monthly basis, and they, you know, gauge where they are in each of those areas. And that's oftentimes very helpful for them to look at some goals that they want to achieve. So, you know, maybe their finances are at a 2. So what do we need to do? You have a job and yet you seem to never have any money. So what type of a budget do you need to come up with? Are you spending way too much money on eating out? Maybe, you know, if you start cooking at home, also that physical part will start feeling better too, because you're eating more fruits and vegetables. Like I said, being able to really help your residents and giving them the tools that they can look and take some time to, and it takes all of 5 minutes for them to do a self-evaluation, but it helps, it gives them the tools to be able to make some changes for themselves. And it's kind of neat. We keep those for our residents, being able to see somebody's progress over the course of 6 months or 8 months or a year while they've been there. So this is a weekly calendar that we use, that we require everybody to fill out the entire time that they're there. And it's really about starting to learn how to plan, how to have a life that is very much in order. This here is, so we have all of our house managers as part of our as part of the work that they do with our residents. They're seeing each one of our residents every single day. They're asking about what they did for that day. Did you go to a meeting? Did you get anything out of it? Did you meet with your sponsor? Is there anything that you need? What do you have planned for tomorrow? And is there anything you need in general? And and we're not, this isn't a 10th step, but it's trying to help people learn about reviewing their day and preparing for the next day. And it really shows that there's somebody in the world that cares about them. So as we continue to look at how do we provide that support and structure and really helping people move from chaos to some calm, serenity living life. So, that we go over them with some grounding techniques of how to prevent an anxiety attack. And part of it is, being able to really help people learn how to do grounding for themselves. This isn't something that you need to be clinically trained to do. It's very easy, and it can really be a lifesaver for your residents. We also want to make sure that we're continuously looking at how to manage stress. So these are just some examples, and I know in Washington you have digital recovery meetings as well, but making sure that those are up and available and that it's being communicated to the residents so they know what's out there and what's available. And being able to help folks that maybe not be too technologically savvy, being able to access those and get on those. This is just another one that was put out by the Ohio Department of Health of reducing your stress and you feel better. Those little reminders can just really be very helpful for people. It's just we want to continuously be working towards wellness and recovery, because if not, we're working towards return to use. So I think one of the things, a lot of recovery houses are based on 12-step programs, or 12-step programs are really fundamentally part of the program, which is fantastic. But I think it's important to recognize that going to meetings and working with a sponsor isn't going to necessarily be the solution for everything. Being able to seek outside help when necessary, and that's a fundamental place that recovery housing operators can come into play. Peer supporters, the staff, being able to help your residents find what are the resources in your area. Where do you need to be able to fill a gap for this person? And then, if you go through and you take a look at these different areas of support that your resident needs, being able to keep a list. So once you find a good eating disorder therapist, being able to continue to use that person, or different food banks that are in the area. How can you continue to help your residents and make it easier on yourself, so you're not always going through and recreating the wheel, and every time that somebody has an issue that you're trying to figure it out again. A lot of times, once you find a good resource, being able to keep a binder so you can easily get to it again. So are there any questions that people have about recovery planning, being able to really support people on an individual basis?
I have a question in the chat box that's just asking if we were going to get the opportunity to talk about what happens when a resident relapses in a home.
Yep, that's very much the next question. So recurrence of symptoms. So when we go through, and inevitably, people do relapse. That's just part of operating recovery housing. It's going to happen. So for us, it's important to have a relapse plan. So for day one, having a plan that is able to be put into place in the event that somebody relapses. And I have to say that most times residents, they don't want to talk about it. They don't want to think about it because everybody comes in full of hope of it's not going to happen to them. We still have people go through and create a relapse plan. So for our organization, what our rule is, or our expectation is that if somebody were to relapse, if they are honest about the relapse, then we can still work with you. But part of our relapse plan is where are you going to go if you do relapse? So most times relapses happen at 11 o'clock at night. And I would say about 50% of the time, our plan for that night, keeping that person safe, is for that person to basically sleep it off in their bed in the recovery house, or in a bed in the recovery house. So as I said, we do have third floor apartments for all of our house managers. So sometimes it's on the couch of the recovery or of the house managers in the house manager's apartment. We just want to make sure that that person is safe. So a lot of times though, if we can get that person to whoever they've put down as their support person, so either family members, sponsors, sober friends, that's often the other place that somebody will go. But to us, it doesn't seem to be a good idea if somebody relapses then to also instantly make them homeless. So we have taken the approach that we're going to slow things down and we're not going to go through and make these, just rash decisions. So our first priority is making sure that the person's safe. If they're, if they're possibly having alcohol poisoning or obviously overdosing, we're calling the police, or not the police, we're calling 911 and making sure that they're getting to the hospital to make sure that they are stable. So in that event, that's our first step. But if the person, they have relapsed, but they are stable, if they need to be able to sleep it off at the house, we can work with them on that. But then as part of the relapse plan, where are you able to stay for 48 to 72 hours, someplace that you can go, that we can go through and take some time and really reevaluate what's going on in your life. So, is it that you're in a relationship and way too much of your time is spent in this relationship? Or is it that you're working way too much? Or that you're not really addressing some of these grief issues that you have? What's going on? What's actually missing? And that takes a lot of self-evaluation. That takes being able to really ask some questions, talk to your sponsor. But we just want that period of time to be able to go through and really reevaluate the situation. But making sure that that resident is safe as well as other residents in the recovery house are safe. You don't, at least for us, we don't want to put somebody who has had, a few drinks in the same room with our other residents who may be triggered. So we want to make sure that the person's safe, but not necessarily in the same area that our other residents are at. We do, if there is a relapse, we do ask, so all of our houses have a private area that the resident can be in the house manager's office, that they're able to go and have conversations and they're able to stay away from the other residents. So first is getting that person safe, making sure that we can get that person back to being a place of being stable. So then so it's important that the organization looks at, what is your relapse policy? There's some organizations out there that one time you relapse, you have to go to treatment, and then you can reapply, or you have to leave and then you can reapply. And that's, that's a very reasonable, that may be a reasonable expectation for your organization. But I would really urge you to look at how can you make sure that that person is also safe. There unfortunately are some places out there that if somebody relapses, they're also then packing their bags and putting them out on the street at 12 o'clock at night. And that doesn't help anybody. I mean, that's just my opinion, but that it's not, we don't think that it's an important idea or a good idea to make somebody homeless right then and there in the midst of a relapse. Being able to make sure that that person has some support and being able to feel that, yes, it is a big deal. It is an issue, but it's not the end of the world. It doesn't have to be, 6 weeks of going out and using and burning your entire life to the ground. So
Hey, Erin, can I pop in
yes,
for a second?
yep,
And I just want to be, I'll put my cards on the table and say I 100% agree with what you're saying about, so no, I'm playing devil's advocate because there are a lot of devil's advocates. So,
yep.
but I want to just throw out the question, how do you answer the question around the sort of trigger question, right? Which comes up in this conversation a lot around other residents needing to have a home where they can be free of the trigger or the insecurity or the or the unsafety of having a person, or just not knowing for sure that everyone in the home is sober because maybe the operator has made a decision to hang on to somebody. Can you speak to that? And I'm not
Yep.
trying to put you
Yeah.
tons on the spot here, but I think we
Yeah.
hear that a
No,
lot, and I'd just be interested in your
yeah,
thoughts.
it's a very reasonable question. So a lot of that is having conversations with the other residents. So being able to have discussions with the other residents. That you're right. We don't want you to be around somebody who's intoxicated, who is high. So we do make sure that, inevitably the person walks in, and it doesn't happen all the time. I shouldn't say that, because sometimes people relapse on passes. They relapse not at the recovery house. Hopefully they're never relapsing while living while at the house. But they leave and they come back and they're either drunk or high. So immediately that person is brought to, as we have in every recovery house, I believe in Ohio, has to have an area that we can conduct private conversations. So that's where that person is taken while they're under the influence. And we talk to the other residents about, you're not to come back into this area. The staff person will take care of what's going on with this person. So the residents are told not to come back to the area, and two, the resident who has relapse is told to stay in this area. Now, we all know that people, when they're drinking or using, cannot be the easiest people to work with. On the front end, we set the expectations that if somebody is intoxicated and belligerent, we will call the police. And if somebody is high and belligerent, we will call the police. All of our recovery houses have good working relationships with the city that we operate in. So they know about us, they're very supportive of us. And we make that very clear. In 7 years of doing this, we've had to call the police one time because people know that. A lot of times when somebody has relapsed, they are remorseful. The other thing of it is sometimes when people relapse, they don't come back to the house while they're actively high or using. It's afterwards. So if somebody does come back, we believe that we have a duty of safety to both that person as well as the other person, the person who has relapsed, the other residents, and that person. But for us, when we've made the decision that it's not just one and done and you're out, we've talked to our residents, because sometimes people will say, well, what about that person creating this this community that people can use one time and then come back to the recovery house and still continue using. Honestly, that really goes to fundamental. If you're in that mindset of still wanting to use, we've got significantly bigger problems than seeing somebody for 30 seconds that was drunk or high. So being able to create that community of wellness and recovery, that it's what we have done is really, it's more that the person, the other residents feel bad for the person, and they can reckon our residents, and I'm sure yours are the same, can see where people have where they've gone downhill, where they're missing, that parts of their program are lacking. And we do ask, as part of the person coming back in, for the other residents to give feedback. So that's part of. So does that answer your question?
Thank you. I just want to be sure we cover that, because it comes up a lot as sort of the main reason why there's the 15-minute policy, what I call the 15-minute policy, right? Where
and I've seen that, but I've also seen that go really bad for that person. And if we can start to change our thinking, that so much of the emphasis of this is preventing the relapse, and two, if we can really look at the culture that has been created, that the other residents in the recovery house, that this is kind of a warning sign to them of this is what can happen to you if you don't work a program, if you're not doing what you're supposed to be doing. So this is kind of a sample plan that we go over with our residents of, you know, only going to women's meetings, talking to, they have to talk to the other residents and get feedback for the residents living in from what the other residents see as downfalls in what they were doing. Meeting with the sponsor or mentor, also getting feedback. A lot of times it involves going to engaging in therapy, possibly a medication adjustment. We always add extra service work. You know, we believe service safe. So there's extra service work that's going to be added. Being able to look at, you know, work life, family, significant others. So, you know, we may be cutting some of those down drastically. After somebody has relapsed, if they're making the decision to move back in the recovery house, then they're coming back in as a new person, which means the restriction period and all of that that comes in with being a new person, that you're starting over from, you know, step zero. So starting at step one, and really being able to make some changes. Now, I will say, if somebody has relapsed a second time living in the recovery house, we still do the same thing as far as making sure that that person is safe for that night or until the next morning, to make sure that person's safe. We have made the decision that we'll hold a bed for somebody for 30 days, but they have to go to a 30-day inpatient treatment. And that just, I mean, if you've relapsed twice, and again, we say that we'll hold a bed. We are not necessarily saying the bed at that same house. That may make sense, but maybe, you know, you need to live in a different part of town, and that's okay too. So we have just made the decision as an organization, and it's worked out really well for us, that we don't want, housing should not be dependent, or not being able to support somebody from a recovery housing perspective because they've had a recurrence of symptoms. And that's really what a relapse is. So we put it more on the organization as a whole of how can we help you get well, if the person's willing to. Now, I would say about 30% of the time, the person's relapsed, they don't want to continue living here. They don't want to continue to be in recovery, at least at that point in time. We try and make things as amicable as we can, and we keep them, we keep the person moving. We support them in moving out. Tell them, call us back if you want to try again. So then again, the restriction period, phone calls, that helping people with struggling with the isolation, and then increasing that fellowship. So that's just kind of a sample plan that people can use themselves. This here, so other residents, so working through privacy. Obviously, living together, people see what's going on, and we have conversations with our residents about, there are certain things that we can't talk to you about because it's another person's privacy. You have eyes, you have seen what's going on. You wouldn't want other people gossiping about you if you were in their shoes. So we're not going to sit here and talk about that person. You can be a friend to them, but they're no longer a resident living here, or they may be coming back. We just do very brief discussions, but we really put it more on that person of how would you want to be treated if you were struggling. And it really seems to solve most of the issues. Now, I'm not going to say that residents don't talk amongst themselves, but we do a pretty good job of addressing that. So how would you want to be treated if you were the person that was no longer living here? Would you want people talking about you behind your back? And being able, again, it's not a tough question to ask, but you have to be able to ask those questions, and you have to give people the opportunity to think about it. And if the person does not return to the house, then we as an organization will hold their stuff for 30 days, and then we tell them that we're going to donate it to another, to the Salvation Army. So, but those are all written as part of the expectations on the front end. The one last part is then, what if the resident is just not in the right place? So, you know, and this isn't sometimes a full-blown relapse, but it's a lot of the symptoms and that are leading up to a relapse, or there's just behavioral issues. Why is it not working is one of the main things to be able to address. Do you have documentation to back that up? And then what other options are there out there for the resident to live in another recovery house. So being able to develop that, network of people in places that people can go. Maybe they need a higher level of support, or maybe they need a lower level of support, and being able to set forth in your resident agreement that, either is this a week-to-week agreement or a monthly agreement. We always do a monthly agreement. So we know that if something's just not working, we can give somebody legally a 30-day notice that this is your last 30 days, and this is no longer the right level of support or right recovery house for you to continue living in. So some of this is really just setting things up on the front end to be able to help residents really know what their rights are, but also your rights as the organization and standards of the organization to be able to perform. Sometimes it's just not the right fit, and that's okay. So I'd like to take a pause to answer some questions here.
We like to say this is the interactive portion of the program, everybody. So if you have thoughts about or just questions that come up, this is the real sort of a lot of judgment calls. It sounds like, Erin, in the midst of all of this. And so I really welcome people's thoughts and questions and even opinions about how they might make some of those calls along the way, or the things that they might think about.
It looks like sorry, it looks like Michael Robertson has his hand up, so I was going to allow him to talk, if that's okay.
Yep, go for it.
All right, you are allowed. Yep, there we go.
Okay, yeah. I just really I'm finding this really interesting. I'm a peer services specialist, and I have a lot of people I come in contact with that are involved in clean and sober housing. And I was wondering about this webinar. Is this going to be later available anywhere to view, or is that a no?
So
I believe we're recording, are we not?
Yeah, we are currently recording it, and it will be posted on our website.
Oh, okay, great.
By I would say tomorrow.
Great.
I'd love if you could put your website in the chat. I know I logged on, but I wasn't really. I just found the topic very interesting. So, yeah, if you could put that in the chat, I'd really appreciate it. Erin, it's a great presentation. Excellent information. Thank you for inviting me.
Happy to do so. Happy to be able to help. So
absolutely.
And the one thing that I would say, and Alan, I really appreciate your question, and Michael, it's important to be able to have these conversations. And we didn't get here by this being the first thing that we tried to do. So I thought initially when we first opened that it was very important to be very strong that, if somebody relapsed, we have to immediately get them out of the house, and it's going to be terrible for the other residents. And let's face it, everybody living in the recovery house has seen somebody drunk or high. Now, that's not an environment that we want to continue to put them in, but being able to recognize that this is a sick person at again, the lowest stage that they can be with a return to use, we feel almost morally obligated to be able to help that person get help. So, and that doesn't typically happen in 15 minutes. And when somebody is drunk or high, they are not good at making decisions. So oftentimes they are making terrible decisions. So we, like I said, we tried it and it worked. And we have, I mean, some of our best residents are people who have unfortunately had a recurrence of symptoms and had to go through and double down and figure out, what causes and conditions, and being able to look at things a little bit differently. So I think on average, the people relapse 7 times before they get to long-term sobriety. So, we wanted to come up with a different way to be able to look at doing some things. And I can say it's worked. We have 6 different recovery houses, and this is the way that we do it in all 6 of those houses. And I would say we have a very much of a reputation of being one of the best quality recovery houses in our area, if not the state, because it is individualized so much, and we are working with residents. There's at no point in time does anybody ever think, oh, you can always use their, because really we have an expectation that there's a whole lot of other things that people need to do to live in our recovery house. I hope that like provides a little bit of context.
Yeah, I'd like to pile on if I can for a second, Erin. I think some language that I've heard that's been helpful for us as we thought through these decision case by case is how do you prevent a lapse from becoming a relapse? And maybe that's semantic, but I really appreciated what you were talking about, that okay, so someone in that moment of insanity does something, and so then there's this sort of crossroads where if they're sort of made homeless on top of all of that, what are the chances that they're going to go to the detox and figure it out and go, and return to health and call us back, as opposed to if they're guided and, language we use, if they're sort of loved back into recovery, right? Where there's welcome and there's options, and they're in charge of those options, and there are people around who care about them and they know that. So we've come to think about the idea that when does somebody need the supportive community the most, right? And it seems to us like they really need it the most when they're in these moments of crisis. So anyway, that's some of the thinking that we've done as we've sort of are looking at our own policies around these things. And there's a lot on the ground. It's just not so cut and dry. This is really easy to talk about midday on a Thursday. It almost always happens, as you said, in the middle of the night on a Saturday. And so when we're not at our best, we're making these kinds of calls and decisions and trying to figure them out. So thinking through the philosophy that we operate from ahead of time and makes so much difference when you're actually in the situation on the ground facing it.
Absolutely. Well said, Alan. And I think that's one of the things that we found to be very helpful was that relapse plan. And like I said, residents hate doing it on the first day because they come in with a lot of hope. And we say, we hope to never have to use this. But in the event that we do, we don't want to be caught with our, twiddling our thumbs that we don't have a plan in place. And that's quite frankly because we got caught at the beginning with we knew that sending the person out into the street wasn't the right call. So how can we have somebody in their life that is willing to have them come and stay with them? And sometimes it's difficult. Sometimes that can be a challenging piece that people have burned a whole lot of bridges. But what we have said is you got to have one person that you can call and to be able to stay. So we don't allow people to put things like going to a hotel or going to a homeless shelter. And if you press hard enough, I mean, we always come up with one person that person can call and at least ask the question to. And we've had situations that, it's been difficult. And that's, I guess, probably where we've had sometimes at 12:30 at night or 11:30 at night that the person, we make the decision as the organization that we put them on the couch in the house manager's area, and that's where the person sleeps for the night. And then we figure out the things in the morning. Also, that person is no longer high or drunk, so they're able to contribute to some of the decision making and, maybe a little bit clearer. But we have a very clear plan that, if somebody is that our house managers or peer supporters are immediately calling, making sure that the person is safe and stable. So 911 may be your first call, but if not, then it's to call our housing director or myself, and we're going to talk through a plan of what needs to happen, and then being able to go from there to really come up with a good solid plan. And we give ourselves 48 to 72 hours of that person staying someplace that we can go through and get lots of different people's opinions, their sponsor, their therapist, to be able to create, we're going to try, we've all made the decision that we're willing to give this a go again. How do we go through and what are we doing this time around to be able to have a different outcome?
So after that 72 hours, would you take that person back sometimes?
Yes.
Just straight back into the house?
Yep. Straight back into the house. So when they leave to go to wherever they're staying, they typically take with them like an overnight backpack with them. toiletries and some clothes, but we kind of presuppose that the person's going to want to do things differently and want to continue down the pathway of recovery. We have found that if we ask people to take all of their stuff with them when they leave at that point in time and then come back, they're more likely to just be out there floating around in the world.
Sends a different message, doesn't it?
Yep.
Yeah.
So I know that you said that you had some announcements. So we're at 2:26 here. So I would say after I can turn this back over to you, and after the presentation, I'll send you an updated one with my contact information as well.
Great. Thank you so much,
thank you
Erin. And Danielle, I've really enjoyed your participation, and you are, I know you two work really closely together, so it's really awesome to have you with us. So I wanted to just announce that a couple of things we have coming up as an organization. We do a webinar like this, hour and a half every month, and we have a couple of great topics coming up. One of them on NIMBYism, so not in my backyard. How do you do neighbor relations in a way, or with your municipalities or cities that create opportunities for your residents to really succeed, and how do you confront that? How do you confront when someone doesn't want you in their neighborhood? So that's one. We have the folks from Kate's House Foundation in Seattle leading us in that conversation. And again, that was really great. We did that almost a year ago, and it was really worth repeating. And then we have the opportunity to have Steve Pullen with us. Steve is really the foremost attorney nationwide in fair housing. He is just does a phenomenal job talking about that. He's going to come and talk to us about the various dimensions of the Fair Housing Act, which apply really in a number of ways to recovery residences. It protects our residents, it protects us as operators. Our existence is protected in some ways by the Fair Housing Act, but it also has some things to say to us about how we work with our residents. And so so we are just privileged to have really, I can't think of a better expert nationwide to come and join us for that. And you know, the one sort of outcome of COVID, I think that's positive, is we can get anyone we want to come and be with us and present to us. So that's coming up as well. So both of those you can register for on our website. That's Walker, WAQRR.org. And then finally, March 4th, we're doing a one-day summit. It's not a whole day, it's 10 to 3. And that summit is going to cover a lot of topics like fair housing and like NIMBYism and medication-assisted treatment in recovery residences. We always reserve time at the end of that day for just topics that operators want to come and talk about, kind of a roundtable discussion. We're going to talk about levels of care. So if you know somebody who wants to get into this world of recovery housing, they want to start something and they just don't know where to start or kind of what the basics are, we've sort of designed this to be Recovery Housing 101. And we're just going to do it in 5 or 6 hours, and really, I guess it would be something like 4 hours actually, all told. And we just really want to make that available to anybody who wants to know more about this world. And obviously stakeholders are more than welcome to join that and give us your input as well. So if you come to that, I mentioned at the beginning that we're giving away some gift cards. If you come to that, you register and you attend, you'll be entered to win one of 10 $250 gift cards. We have a partner who's funding this effort. And the other part of that I want to close with this is that we are really trying to grow our contact list. So we want to know about recovery residences that are out there in Washington. Believe it or not, there is not a comprehensive list of recovery houses in Washington State, recovery homes. And so we are working to create that, and at very least so that we can be in touch with them to let them know what we're up to and the kind of professional development we have available. We want to talk to them about the accreditation process and so on. So if you give us information about at least 1 or 2 recovery residences that you know of that are non-Oxford houses, we know about the Oxfords. They do a great job of telling us where they're at and how to get a hold of them. But non-Oxford houses, if you refer us to somebody, we will also give you 1 entry into that drawing. So you have the opportunity to have 2 entries in that drawing. If you give us some of that information, you can do that via email, or if you go to our website, walker.org/connect, there is a little form there that you can fill out and send that our way, and your information will be on there, and we'll enter you to win. So long-winded way of saying we have a lot going on. We want you to participate with us. We're excited that you joined us today. We're super thankful. We will send out, we're going to post the webinar, and so you'll have access to the great information that Erin shared. And so you'll find that on the events page. We'll just put a little link to the recording right there. So Erin and Danielle, thanks so much again for joining us. You're doing great work out there, and it's wonderful to have you with us.
If I could just jump on, I will be sending up a follow-up email, which will have the quick survey just about this event. But when I do that, I'll also make sure to attach a PDF of the PowerPoint, and I will attach a sheet that you can fill out with that information about any recovery housing that you know of that is the non-Oxford, and it'll just be a really simplified sheet where you could just plug it in and then just send it back to me and my email. I will make sure to have that posted.
Perfect. Yeah, we really need your participation in all of this, and so we're incentivizing it, but mainly we just want to stay connected and grow our network. So Justin, thank you for the follow-up. So be looking out for that email. We really want to hear your feedback on this presentation and anything else you want to share with us. Final thoughts, Erin or Danielle? All right. Well, thanks again, you both, and thank you, Justin, for manning the technology, and we look forward to seeing the rest of you in a future webinar. Take care.